Good morning, colleagues from Kampala, and for colleagues joining us from elsewhere in other time zones, good afternoon and good evening. Welcome to this session on improving the quality of service delivery by community health workers in Uganda through implementing the electronic community health information systems. My name is Chibomwe Msukwa, and I will be your moderator for this session. I am a health specialist working with UNICEF here in Uganda, and I am responsible for health systems strengthening. As a little bit of a background, in 2018, the Ugandan Ministry of Health, with support from partners, developed a community health acceleration roadmap with 6 priorities. Among these priorities, leveraging IT tools was priority number 4. The roadmap continued to be revised, and in 2019, the revision of the roadmap crystallized this priority, and it read, Uganda was going to invest in the scale-up of appropriate technology for community health implementation and supervision. We're talking about real-time, long-term care coordination and active monitoring and analytics. In 2020, the Ugandan Ministry of Health, with support from partners, developed a national system known as the Electronic Community Health Information System, or in short, eCHIS. The eCHIS is critical to the government's goal to improve the of data available for decision making. This critical milestone was with the government of Uganda's National Development Plan, which has a program on digital transformation. And its stated aim is to increase ICT penetration and use of ICT services for social and development. So colleagues joining us from everywhere, welcome again. We would like to get you involved in this discussion. And we will have some questions that we would like you to respond. To get an idea of your experience in this area, can you kindly respond to the 2 questions in the poll? The first is, does your country have an electronic community health information system? And the second is, does your country provide any form of compensation for community health workers? If you are able to respond to these questions, then we can engage in a conversation as we continue with this presentation. Just to give a little bit of time for colleagues to vote and contribute to this discussion. Okay. So let me continue by introducing our speakers today. We have 3 speakers today representing the Ministry of Health, a technology partner and an implementing partner. This is representative of the collaboration needed across sectors to successfully launch an eCHIS. Since we have just a little bit of time, I would like us to head straight to our first speaker. I would like to introduce Solomon Muhumuza. Solomon is a data governance and security specialist at Ugandan Ministry of Health. He has served in several capacities at the Ministry of Health's Division of Health Information. He's been supporting major digitization initiatives aimed at improving the application of digital health technologies with the objective to deliver high-quality health services to all citizens of Uganda. Someone will be sharing context around the country's journey to create an eCHIS. Over to you, Solomon.
Thank you, Jim, for that amazing introduction. Let me know if there are breaks. I'll be turning off my video to just maximize bandwidth. But today I'll be looking at the journey for contextualization of the electronic community health information system in Uganda. And we could go to the next slide. As Achim has already introduced me, I work with the Ministry of Health. Well, I'll start talking about Uganda, as of course. Uganda is located in the eastern part of Africa. You can refer to it as the Pearl of Africa. And Uganda has a population of 45.7 million people and has an urbanization rate of 24.9%. When we look at mortality rates within the country, we have maternal mortality at 336 per 1,000 live births, and infant mortality right now stands at 41.5 per 1,000 live births. When we look at the infectious disease risk, it is a very high risk area here in Uganda, and we've been battling with the Ebola outbreak in the recent weeks. Previous to that, of course, we had a fair share of the COVID outbreak. And looking at the digitization efforts within the country, the mobile phone subscription right now stands at 53%, and the internet use stands at 12.16 million. And when we look closely at the different infrastructure that has been set up within the country, we have internet penetration of 26%. Looking at, as had already mentioned, I work with the Ministry of Health, looking at our vision at the Ministry of Health. We could go to the next slide, please. And of course, looking at the mission as well. The vision is to have a responsive, resilient, and people-centered health system that protects and promotes the health and well-being of all the people in Uganda. So the vision is leaving no one behind, and the mission looks at to promote and ensure universal health coverage in Uganda through evidence-based and technically sound policies, standards, strategies that are client-centered. So those in Uganda here, that is our vision and mission at our Ministry of Health. Next slide, please. Next slide. Moving on to the community health service delivery that we're talking about today, we see that our community health workers at the core of everything we do at the community level. And the community health workers, whom we refer to as VHTs within our system of village health teams, these carry out health promotion at community level. They help support maternal health and family planning. They assess illness of children under the 5 years who are within the communities. As you all know that most of the children die in the communities, those ones that are under the age of 5, due to diseases like malaria, pneumonia, and all that. So they help to assess and provide the needed medical attention and also referrals where there is need. The VHTs help to follow up care at home, and at the same time, they help to see that the newborns are cared for and are in good health. They also help, or the community health workers also help to deliver essential health services in response to outbreaks. From evidence, we've had Ebola outbreak. The community health workers have been very key in this response. The COVID-19 outbreak, we got to learn a lot that the community health workers actually provide a lot of support and are very central to us defeating the outbreaks that we face as a country. Next slide. And you could be wondering, where do the community health workers therefore fit? And as earlier mentioned, that we refer to them as village health teams. So they live within the communities with the households they serve. And we see that during the provision of services, these VHTs serve up to 100 households. So we could be having 2 VHTs within a village or within a community that serve a maximum of 100 households. They are then supported by, at the parish level, from the community, we go to the parish level, they're supported by parish coordinators, and then we move on at sub-county level, where they're supported by health assistants who are at health facility levels. And then they help that linkage to the district and then to the National Ministry of Health. Next slide. So in brief, that is the hierarchy, and that's how the VHTs are fit within the system. So looking at the community health service delivery, we've had bottlenecks, we've had challenges, and the VHTs, of course, have pain points. But we shall be looking at the bottlenecks, and it's upon this background that we came up with the electronic community health information system. And the first bottleneck is actually targeting and follow-up challenges. From my previous presentation, I'd mentioned that VHTs help with follow-up of patients within a household, see how well they're doing, how well they're recovering. It is a challenge for a VHT or community health worker to look through manual registers where these the 100 households are registered and with their members within these households. And it's very much difficult to trace who needs follow-up, who needs to be targeted with which service. So that has been a major bottleneck in the service delivery. The other one is management of bulky paper tools, which is not easy, especially in rainy seasons, now that we know that the VHTs move around in communities with paper. The other one is having to move significant distances to submit reports, which makes it impractical to get near real-time data. We saw that during the COVID-19, when we had lockdowns or restrictions in movements, VHTs were not able to move these distances because there were no transport means. But also from the routine, from the operations, it's very difficult to cover these distances. There's also significant burden of reporting. We know that there are ever increasing data demands, both from the government and partners as we work. We need more visibility, we need more information, we need, and that has resulted in more reporting needs, which is actually a burden for the VHTs. And lastly, the quality of data that we get through manual data collection process has actually been maximized. However, we still see that there are errors that we can't explain, and this definitely calls for a change in strategy. Next slide, please. And therefore, as a country, what has been our motivation for the digitization of this community health service delivery, given the bottlenecks that we have? As a country, the government of Uganda, through its National Development Plan 3, calls on sectors to leverage ICTs to optimize health service delivery, and different MDAs or ministries, departments, and agencies are all responding to this call and are using various ICTs to make sure that service delivery is improved. And we tend, as government, of course, as Ministry of Health, we intend to leverage on these ongoing efforts to digitize most of the service delivery within the country. The other one is that there have been significant improvements in digital tools, making them affordable and applicable in low resource settings. And definitely we have a classic examples of the global goods, which are open source, and governments or ministries of health will just have to tailor these specific tools. Next, please. Yes, so as I'd earlier mentioned, from Ministry of Health perspective, so in our current strategy, the ministry intends to commit to strengthening her community level implementation with a focus on disease prevention, and that aims at decongesting health facilities. If there is a service that can be provided at community level, if we can detect, diseases and be able to treat them, for example, like diarrhea, then we shall definitely leave room for the health facilities to give quality services to those who have been referred or to those who need them. Next, please. Okay, now the country objective for digitization includes implementing a digital job aid for community health workers or VHTs with reporting as a passive process. We've noted that from previous experience, when VHTs use manual registers, they have focused so much on, on how the data is captured so that our quality is not compromised. But we know that paper tools don't have validation mechanisms. So we're now saying that let the attention not be on reporting, let it be on service delivery, and reporting is more of a background process. So specifically, we're trying to ensure appropriate governance framework for implementation of community health information systems in the country. Before, we've had fragmented systems being implemented. We've had duplication, so we are trying to align that bit. We're also trying to ensure that we have upgrade functionality currently in different program and function-specific digital tools into a single government-owned digital community health information system. As I earlier alluded to, you'd find that most of the tools being implemented then at the community level, the digital tools were more disease specific, but we can have all that into one. We know that our members within the communities get diseases in an integrated way. And lastly is ensure interoperability of the community health information system with other Ministry of Health systems to facilitate referral, commodity accountability, reporting, and surveillance. Next. My colleagues will be talking definitely about the systems we've integrated with over time. So lastly, for my presentation, I would like to share this specific journey that we've taken that is focused on the Community Health Toolkit. So we had Living Goods in 2016, develop a mobile application, which is referred to as mHealth or mobile or mobile smart health that was developed, and then at that time was rolled out, but the development was more of a partner initiative, just as the other partners I talked about. And then we had BRAC also adopting the CHT, the Smart Health app, and they also rolled it out in 2017, and at the time was covering 9,000 community health workers. But between the space of 2019, we launched the CHT officially here in Uganda and focused on capacity building. And it's within that time that we formed the iCHIS, which is a consortium of implementing partners and at the government. We have UNICEF, we have Rockefeller supporting, and we, as a government, we developed a comprehensive tool that we introduced into the public sector, and it became the official community health information system. And we've gone ahead to further make further adoptions and ensure that this tool is comprehensive. Thank you, Chim. Over to you.
Thank you so very much, Solomon, for your presentation and insights. It is noted, and we know that if we, as a country, are going to achieve universal health coverage, we see that it is very important to strengthen community health systems. It is at the community where people that need services most are residing. So strengthening community health systems, including community health information systems, helps to bring services closer to the people, and data is central to this. Colleagues joining us online, if you have any questions, please put those questions in the chat box. We will have time at the end for Q&A with the speakers. Next, it is my pleasure to turn into our technology partner. This presentation will be made by Jatuhaisen. She is an accomplished professional communication technologies development, Kampala. Georgia will share the benefits of eCHIS in the delivery of services by community health workers or village health teams, as we call them in Uganda. So back to you, Jovia.
Thank you, Chim, for the introduction, and thank you, Solomon, for the very comprehensive talk that you've given earlier. So as MEDIC, we have supported the Ministry of Health in the design and the development of the different use cases in the eCHIS. To talk more about MEDIC, we advance equitable care and strengthen global health systems by building, innovating, applying, and scaling open source, cost-effective digital health tools in collaboration with local, regional, or global partners. Our global team, on the other hand, aims to revolutionize the digital community health by building free and open source technology and prototypes, open source open access resources, and a community of practice as a means to achieve universal healthcare coverage. Next slide, please. The Community Health Toolkit is a collection of open source technologies and open access resources developed by a community focused on global health equity. We envision a world where primary healthcare is equitable, accessible, and delivered by people who are trusted in their communities. And the eCHIS is built on the Community Health Toolkit. And as we continue, I'll talk more about the different core frame components that have really benefited in the delivery of services by VHTs. Next slide, please. The CHWs core framework is a highly configurable software platform that makes it easier to build scalable digital health apps. It runs offline, so the app stores a user's data locally on their device so that the workflows can be completed without syncing to the server. When a connection becomes available, data will automatically sync to and from the server. Offline fast technology enables health workers and community health workers, on the other hand, to carry out important duties, even when opportunities to sync may be weeks apart. It also works on multiple devices and supports multiple users in the health system with integrated care workflows. Next slide, please. To better support the VHT in the delivery of services at the community, the CHIS leverages these specific core frame components of the eCHS, which are the longitudinal profiles, task and scheduling, care guides for decision support, and in-app analytics features of the CHT framework with the iCCM, RMNCH talk monitoring use cases from the standard care package for public sector VHT. Next slide, please. So to talk more about the specific core frame components that I've mentioned earlier, the first one is the longitudinal profiles for patient-centered care. Community health workers, in this case, for the VHTs, supervisors, for the health assistants, families, and individuals have profiles with unique IDs. Profiles have condition cards to show critical information at a glance. The VHT has all this information on their mobile phone. That way, they do not have to move around with bulky books that can be destroyed by different things, say weather or theft. But this way, there is no data loss, and that at all times they're able to access the information when they need to. Next slide, please. The next one is the care guides for decision support. Care guides include protocols for home visits, screenings, assessments, follow-up visits, supervisory visits, and much more. For example, if a VHT has to go to the community and carry out an assessment of an under 5 child who is presenting specific symptoms, the VHT is guided through these processes in the app. And that way, first of all, there is we remove the issues of whereby they are going to administer wrong dosages to this specific client in the community, because at the end of this assessment, the VHT is guided on how to administer this treatment, how to give it, also what dosage, but also if the case is severe, they're also guided to refer this specific client. Next slide, please. Then the other one is tasks for schedule management. So tasks surface important actions for the right person at the right time, guiding the VHTs to families or supervisors to follow up with a specific VHT. I can say, for example, if a VHT has carried out an assessment on this under 5 and they've treated, Ministry of Health protocols guide that the VHT is supposed to carry up carry out a treatment follow-up, but if they refer this specific child, they're also guided to do a referral follow-up. And this happens within 3 days of this specific service that they have given to this specific child. So within those 3 days, a task will pop up on the task section of the app. That way, the VHT is always knowing how many treatments follow-ups do they have to make. How many, say if it was a pregnancy visit that they made in the community, how many pregnancy visits do they have? How many pregnancy follow-ups do they have to do? So they are guided on these specific actions so that they are able to reach out this person at the right time when they should. And if it's for a supervisor, if a VHT, for example, has run out of a commodity, the supervisor is alerted. That way, they're able to follow up and support this VHT to get a refill of that specific commodity. Next slide, please. So within the app, we have in-app dashboards that help to track the metrics for an individual VHT. These visualizations help the VHTs or supervisors and help system officials to make data-driven decisions. So within the app, the VHT is able to see how many households do I have in my catchment area? How many under 5 children do I have registered? Or how many treatments have I carried out this month? But also at national level, all this data that is collected within the eCHIS is aggregated to a dashboard. And that way, those other levels, they're able to make data-driven decisions because we have data coming in real time. Thank you. Next slide. So the eCHIS is designed to be interoperable with other digital systems, including complementary apps or other apps that are already existing, and also other national health information systems. Currently, we have the CHIS. Currently the eCHIS is integrated with DHIS2, but also we have works that are ongoing to have it integrated with other national level systems that include EMR, CHW, the Community Health Worker Registry, among others, but also like I mentioned, the eCHIS can be interoperable with other apps because there are APIs that can support that. These integrations will allow for data to move between different software platforms while maintaining data integrity. Next slide, please. So designing for the eCHIS, different workflows, we followed the human-centered design process to guide this. So we had a series of requirements gathering at all levels, at national level, at community level. This way we are able to work to deliver this this eCHIS. It's able to support the users at all levels as it should. We had different user acceptance testing sessions at all levels, and that way the feedback did inform the changes we needed to make in the different in the design of the eCHIS. So maybe to talk more about these specific phases in the human-centered design process, each phase includes expansion and contraction. So discover opens up the field of possibilities. Define narrows in on them with synthesis. Ideate generates many ways of solving a problem. Prototype helps the most viable or desirable or feasible ideas rise to the top. Test results in lots of feedback, like I mentioned earlier, the different UATs that we had, and iterate uses synthesis like define to specify which parts we are going to change. And this was very helpful in the design of our workflows for the eCHIS. Thank you so much. I'll hand over to you, Chim, to introduce the next presenter.
Thank you so much, Jovia, for the presentation. I think the key message is clear, which is that tool design is important and it shouldn't be overemphasized. Tools need to be convenient, intuitive, and must meet the needs of health workers and ensure that their work is eased while improving the quality of care. Colleagues, earlier when we started, we talked about a poll. Unfortunately, the poll did not run, but we're trying to figure out how we can get that to run. And when we are able to do that, we'll draw your attention to that. Finally, to wrap up with regard to our speakers, I welcome Monica Mugisha. Monica is a Senior Manager of Digital Health Operations with Living Goods in Uganda. Monica has over 10 years experience in information and communication technology with a passion for using technology to enhance service delivery and positively impact lives. Monica will share lessons.
Thank you so much, Jim, for that introduction. Thank you, Jovia and Solomon, for really laying the basis for my presentation. Like has already been mentioned by Solomon, Living Goods as an implementing partner in eCHIS. Living Goods is an organization that saves lives by supporting digitally empowered CHWs in Uganda, whom we call VHTs, to help families in need to easily access the care they need. Over time, we've learned that a holistic approach to this is really important. It's not enough to just digitally empower CHWs. It's also important that on top of digitally empowering them, they should be well equipped with the medical commodities they need, as well as continuous training to ensure that they have the skill they need to deliver service. However, we've also discovered that it's important to also supervise them adequately, offer them supportive supervision to ensure standardization of service, but also be able to identify gaps as and when they arise. Like Solomon mentioned, in Uganda, VHTs are volunteers, but we've learned over time that it's also important in order to deliver the impact that we look to achieve, to compensate the VHTs for the services they offer. COVID really, opened our eyes to the role of these VHTs at community level. So it's important to consider compensating them for the service. Next slide, please. So like Solomon mentioned, in 2019 through to date, eCHIS, the journey started, and we used the implementation methodology, as you can see it there. We did a landscape mapping where we were to identify players or partners out there in the ecosystem. What are they doing? What are they covering? Especially those that are using digital tools. After that, we were able to do a bottleneck analysis. Like Solomon mentioned, he listed a number of bottlenecks there, where we identified a number of bottlenecks and were able to prioritize those that can be closed with digital interventions. Once those were prioritized, we're able to do a technical design through the human-centered design, where we involved users at all levels to ensure that it's the tool that will be developed will be usable, but also appreciated by the users that it's meant for. UATs, user acceptance tests were done on the prototype, and the user feedback incorporated into this prototype to develop the now eCHIS. User training was conducted and implementation in the field done, and now we are monitoring and doing continuous improvement as and when need arises. Next slide, please. Okay, I wanted to give us a view of the journey so far of eCHIS. So far, eCHIS is implemented in 9 districts, reaching a little more than 1,600 VHTs. Like you can see on the right, as highlighted with the colors, BRAC has implemented under the funding from UNCDF, has implemented in 4 districts like listed there and reaching a number of VHTs there. Ministry of Health has implemented in Maracha with the support from JICA, and then Malaria Consortium 2 has implemented in Buyikwe, and then Living Goods under the iCHIS project, which was funded by UNICEF and Rockefeller, has implemented in Lamo and in Tungamo, and also Living Goods each two has implemented in Oyam district. So those are the 9 districts reaching 1,642 VHTs. Over to the next slide, please. Okay, I wanted to give us a view of, and I could have, alluded to this as we spoke through, but we have been able, through the eCHIS project, 1,600 VHTs have been equipped with smartphones, trained on the service areas as well as the application eCHIS. Under the iCHIS project, we realized that, there were challenges of charging and for the VHTs of charging this equipment that we had, handed them. And under the iCHIS project, over 500 VHTs were equipped with solar charging and lighting systems. Also, capacity building has been conducted at both the national and subnational levels. The national level really for system administration, troubleshooting and management. At the subnational level for supervisory, as well as the VHTs themselves. We've also been able to, have agreements to manage the phones and the solar equipment that has been handed over to the VHTs. We've also trained, provided some training to the VHTs as well as their supervisors, but also done refresher trainings for VHTs to ensure continuous improvement and learning where there are gaps, but also to ensure that the skill they have picked is not dropped, retention of knowledge. Over to the next slide, please. From the lessons we've learned, like Solomon mentioned, over the years we've noticed partners, come in with different funding, implement projects and researches, but over time, once the project is closing, government cannot take on these projects because they have not been designed or engaged from the very start. And designed in such a way that they are sustainable and government can therefore take ownership. So we've learned that, even during the design, it's important to have government in the leadership, but partners also scoped and leveraged on, especially with the investments that have already been implemented in very various areas. But also the human-centered design is critical when it comes to systems design. For the implementation approach, a holistic approach is really important. Like I've mentioned, it's not enough to just digitally empower these VHTs. It's also key that you have them well equipped with the medical supplies and continuously trained to ensure skill knowledge retention. But also when it comes to supervision, it's important to offer them supportive supervision to ensure as and when they encounter challenge, they're well supported, to ensure that the service they offer is standardized, and if there are knowledge gaps realized, go ahead and do some refresher training. Also, capacity building, we've learned that it's not a once-off. It should be a continuous process, and not only at the VHT level, but also at the national level, as and when technology changes, as and when the approach in the community changes. It's important to continuously do capacity building. Refresher trainings, which I've just pulled out there. Frequent refresher trainings are important and critical to ensure knowledge retention and as well as addressing gaps. I also wanted to pull out a bit of device management, considering the cost of these devices. It's important to have a tool or an application that can track these devices. It's also, we've learned that the process, device management process should be institutionalized by the government, especially because, we are looking at eCHIS at scale, and therefore managing these devices at scale could be a challenge if we do not have clear processes and systems to manage these. It's also important, we've learned that when we do a cost sharing with the VHTs as we hand over these devices, they handle the devices in a more responsible way with better ownership and responsibility, therefore, increasing on sustainability. Over to the next slide, please. Thank you so much. Using the AIM tool, or what we call the Assessment and Improved Matrix, which was reviewed in 2018, there are 10 areas that we have recommendations on. However, I would just like to highlight a few. One is the refresher trainings, continuously training the VHTs on areas where we've identified gaps or on areas that are new. For example, Ebola has come through, ensuring that they're well equipped and skilled to handle the support, to offer the support that there is need to. Also adaptation of the pull system by the government. Currently, government is using the push system where they deliver commodities to the health facilities, and then those deliver to the community health workers. But there's no, this is not based on consumption. It's important to look at consumption and therefore be able to push the commodities according to consumption. Supervision too, there are structures currently, supervisory structures, but it's important to set programmatic specific targets for the CHWs, as well as offer regular supportive supervision and mentorship. I also like to highlight incentivizing the VHTs for the services they offer is also important, as well as in linking the eCHIS to the national health system to cover, to close the CHW health facility referral loop to ensure, if a VHT refers a case to the health facility, they are able to identify that, yes, this client has gone to the facility, and vice versa once the referral is completed. Over to the next slide. Finally, using the community health worker programs maturity model and toolkits, there are 3 areas where, which is covered in 3 areas. There are recommendations there too. It's important, it's recommended that we have a minimum standard package of care. Like I mentioned, there are various partners or, covering different areas, but it's important to have a minimum package of care, especially for the digital tools implementation. It's also important to have a digital profiling and tracking of the CHWs, as well as digitizing the training curriculum for continuous professional development of the VHTs, as well as their supervisors. Regarding the enabling environment, that is the policy and technical infrastructure, it's important to recommend that capacity building of the technical personnel at national, regional, and district levels is well managed, so that they're able to manage the system that is implemented and support the VHTs to offer the service. But also, like we mentioned, the challenge when it comes that for the reporting to be done, the data has to be synced from the phone to the server, and therefore there is need for data bundles or internet. It is recommended that eCHIS is 0 rated by the telecommunication companies, government, so that, this brings down the cost of bundle purchase, which is quite costly, like we've learned from our experience. Finally, from the existing eCHW digital health, continuous mapping of the digital partners in the ecosystem has been dubbed very important. Having a minimum viable product for the eCHIS, which work has already started and is in final stages, as well as defining the minimum set of indicators for digital monitoring and evaluation, as well as integration of the tools with the national systems, like those at the health facility, as well as DHIS tool to improve on reporting. Those are the lessons and recommendations we've learned as implementing partners. Over to you, Chim. Thank you so much, everyone, for listening.
Well, thank you very much, Monica. I was just checking our participants joining us from several different countries. We see colleagues joining us from Village Reach. We have colleagues also joining us from Uganda, of course, and Mozambique, past Mozambique, as well as you said, Cote d'Ivoire, and others. So we welcome you colleagues to ask questions, and also we have about 15 minutes before the end of the session. So colleagues, if you are able to ask questions, we'll be happy to take those questions. Meanwhile, as we're waiting for colleagues to ask those questions, just some questions to our presenters. And the last one is to Monica. The first one is to Monica. Monica, from the implementation point of view, how have you managed regarding device management? We use smartphones in scaling up these approaches, and these phones can be fragile. They fall, they break, and often they are a target for thieves. So you might get some stolen, etc., etc. But given your experience for the past many years you've been working in this area, how have you managed this? So that would be for you, Monica. And for Solomon, from the government's perspective, what approach are you taking for integration? Because I'm sure, and as we presented, the decision to adopt a single eCHIS for Uganda was not taken long time ago. So for those that were already in existence, what is your approach to integration? So shall we start with Monica and then we come to Solomon?
Thank you so much, Jim. And the device management has really been such a, can call it a pain for lack of a better word. And that's why I had to pull it out even during my presentation. One, as you've mentioned, they can be quite expensive and we're working in rural areas. So one thing we've done is to ensure proper tracking. Of course, we've realized over time that the tools to do real-time discovery, for example, a device I have in my hands, discovering it real-time and knowing where it is, which line is in it, and all that has a lot of dynamics and also can be costly. But I think with the partnership with government and other implementing partners, as well as funders, we can be able to identify a tool that can be able to track these devices real time and monitor location, as well as who is holding these devices. So that is important. For as Living Goods, what we've done is just come up with a way of tracking these devices. We've also gone ahead to engrave them because the devices we have, yes, like you've mentioned, are smartphones, and we buy from the suppliers as they are, according to what is currently being manufactured, but also what is meeting the requirements of the application. So we've gone ahead to engrave them so that they are identifiable as they're out there. We've also gone ahead to have the VHTs sign an agreement to take care of these devices, but also have a cost sharing as we are handing over these devices. We do a cost share, and we've seen that it is improved the ownership of these devices and responsibility by the VHTs to manage these devices. But my takeaway here is that we need an application, a tool that can be able to track these devices in real time as and where they are. And if there are any changes, then these can be highlighted or sent through for action. Thank you. That's what I can share from the implementing partners perspective. Over to you, Chim.
Thank you very much, Monica. Shall we go to Solomon? And when we come back from Solomon, Monica, I would like you to tackle a question from Edwin. Are you able to manage or track the commodities that the community health workers are using? Yeah. Over to you, Solomon, first, and then back to Monica.
Thank you. Thank you, Chim. As part of looking at what was already existing in terms of the community health formation systems which were previously deployed. We now have a digital health subcommittee, which is able to evaluate all these other systems which were previously in place to ensure that they are comprehensive and they cover all the service areas. So the ones that so far what we've evaluated has not been comprehensive, and we've been in talks with partners. For example, we had 196 VHTs in OYAM migrate to the government system, and we have more migrating because one, the partners appreciate both the development and implementing partners appreciate the functionality that is in the government system and the support that is in place. So we have mechanisms in place, and if we find that the tool which has been previously implemented is comprehensive, then we go ahead to have interoperability or sharing of data. But as a nation, we tend to have one dashboard or one data warehouse, which is housing all the data from different applications. But for now, we've not, from the evaluations we've done, we've not found any other comprehensive app that the government would be taking up and ensuring that we collect that information into one data warehouse for use. But we have mechanisms in place over teaching.
Thank you so much. Solomon. Yes, please go ahead, Monica.
Yes, and yes, the tool has a way of tracking commodities or monitoring commodities at VHT level. But I would like to call in my colleague Jovia from the technical technology partner who are actually implementing. She can be able to throw more light on how exactly this is done.
Thank you, Monica. Yes, the tool has a stock monitoring workflow that was designed and developed. So one, the VHT is able to log in all the commodities that they have at hand. And every time they carry out, either they treat and they administer this treatment or give out a specific commodity, say if it's a family planning commodity, or it is condoms, or they've used gloves, or it is an MRDT. As soon as they finalize on that specific workflow and submit, automatically the stock is deducted. Whatever stock they've administered is deducted. So that way they're able to keep track on what stock they're having in their medicine box. But also, like I'd mentioned, the supervisor is also alerted when a VHT has run low on a specific commodity. That way they're able to support the VHT to get a refill of the specific commodity. So that, hopefully that answers the question.
Thank you very much, Jovia, for that response. We do have another question. Thank you, Fred, that question. Can I ask Solomon to respond to this question? What incentives do you give to community volunteers to keep them motivated?
Thank you for that question, Fred. One, the volunteers are facilitated for all the activities. If they have to do the training, they are facilitated. Transport refund is given. Monies for lunch is given, and data bundles are given so that they can be able to submit the data. But as a country, we've now come up with the Community Health Strategic Plan. And this Community Health Strategic Plan, which was approved last month, is going to look at how these VHTs are compensated for the time that they give in the service. So that is the direction the government is moving towards too, and will be ensuring in getting resources to be able to have these VHTs compensated. But at the moment, all the necessary facilitation is in place to keep them motivated and performing the way they perform. But thank you.
Thank you very much, Solomon. Colleagues, we do have 5 minutes before the end of the session. I wonder if we have other questions from online participants. We unfortunately have not been able to run the poll, but would have been happy to see what is happening with other countries. Let me just check with my colleague, Selassie. Are you able to do that? Yes, the poll has been posted in the chat. So let's just use these last few minutes to see what's happening in other countries. Do we have anything coming through? The poll is, the poll questions are as follows. Does your country have an electronic community health information system? Yes or no? And the second one, does your country provide any form of compensation for community health workers? Yeah. So we are asking respondents to respond with 1 or 2, and yes. So we have Saki indicating that yes, of course. Abid, yes. And Fred, yes to both, but not harmonized. And Natasha, yes. And Godsway, it's yes to the second one. And Edwin, yes to the first one. And the second one, yes, but not consistent. So I guess what is emerging is that we probably need to support coordination and realignment to make sure that these efforts can contribute to the greater good. Colleagues, we have only 2 minutes to the end of the session. And I wanted to thank everyone who has managed to spare time to participate in this session. Thank you for your questions, and thank you to the presenters today. Also want to appreciate the Rockefeller Foundation for making this work possible in Uganda. Thank you, colleagues, and have a fantastic day, afternoon, or evening. Over to the technical moderator.